I would say the major, most exciting focus in research in prostate cancer are two things. One is the development or the identification of new therapeutic targets and the development of new drugs. And in particular, we've seen how immuno-oncology agents work very well in many other cancers, lung cancer, kidney cancer, even bladder cancer now, which have been pretty resistant tumors in the past, but they have not worked very well in prostate cancer. It's just one of the other things that distinguishes prostate cancer, along with its genomics, from other tumors. And there's a lot of effort to understand why they don't work in prostate cancer and how they could be made better. The other big area is to understand resistance to new generation androgen receptor antagonists. So for many decades, going back to the 1940s, this is classic history in urology, and the litany of prostate cancer urologists identified that castration palliated men with metastatic prostate cancer. And then in the 1940s, when that was described, there were two ways to castrate men. One was surgical removal of their testicles. The other was to give them estrogen, and both of them were problematic. So fast forwarding to the 1980s, some injectable drugs came along that induced medical castration, and that worked. But prostate cancer in general figures out ultimately how to start growing, even though it's being deprived of its main fuel, which is dihydrotestosterone. And so in the last 10 years, there have been some newer drugs, enzalutamide, darolutamide, apalutamide, and there's one other one on the market, abiraterone, that turn off the androgen receptor, so that when cells, prostate cancer cells, click on their resistance mechanisms, even though there's not much androgen around, these drugs prevent that from happening. But there is, and patients live longer because of the use of these drugs. That's been demonstrated clearly. However, in about 10% of patients, they exhibit primary resistance to these drugs, that they don't work. And in almost all the others, eventually resistance emerges. So another big focus of work is to understand what causes resistance to these very effective agents, so that we can do additional add-on therapies. And I think those are going to be the two big areas probably in the next 2 or 3 years in prostate cancer.